Hi, my name is Chris Anderson. I'm marketing manager at NordicNeuroLab. Today we have an interview with Jetro Tuulari. He's associate professor in Turku, and he and his colleagues have done an interesting study on how to find procedures that could reduce the use of anesthesia, if I'm correct.
Yes.
It will be nice to hear your background, Jetro, so you could start with that. First of all, I would like to hear what's your background in terms of study, and why did you start this study that you actually did?
Cool. Yeah, thanks for having me, first of all. My background is in medicine, and I did my PhD on brain changes of morbid obesity, so like a really excess overweight, and weight loss surgery. So this was all done in adults, and um, after getting my PhD, I changed to development or brain development, so neuroscience of the developing brain. The FinBrain study that I am involved with or I'm working for right now is really about genetic and early life exposures and how they might affect the developing brain in many ways. And we've done studies or measurements for infants and now up to age of 5 years for our participants. It's a progressive study, so we're looking forward to starting new measurements at age 9 years. And that's going to happen soon. So that's basically probably the kind of background why we have, with my team, made a review on how studies have reported successful or improvements in data acquisition in pediatric populations. And of course, our review mainly focused on the studies that, at least at the first measurement point, enrolled infants or neonates. Yeah.
So you started with basically infants, and then you went up to 5, 6 years old, and now you're actually looking further up the age of pediatrics.
Yeah,
Correct?
exactly. So kind of the whole cohort was started in 2010 or 2011, depending on whether or not we calculate the piloting phase to be included. So that means kind of our participants are turning nine now this year. So
Okay.
that's kind of, we're looking, of course, want to kind of continue with the longitudinal component of the study to later ages as well. So now it's kind of pre-adolescent, and then it's going to be adolescent scans and data collection later on.
Yeah, nice. And the study that you did, when I read through it, my perspective of it was more that the purpose of the study was to find procedures that you could use in research, because anesthesia isn't ethical to use on healthy children. Is that correct?
Yeah, so that's basically the main goal. And of course, this is a review article, and we have kind of our entry criteria was of course, infants, and the studies should have at least at the initial time studied infants as well. So it's more about baby scans, if you will,
Yeah.
how to optimize them. And you're exactly right. So for non-clinical purposes, anesthesia is not optimal. At least, there are some reports that it might be harmful for cognitive development, but of course those are done in small samples, and kind of course for research purposes it's always important to try to minimize the interventions and stuff that we have to somehow do in order to get the data. And as it turns out, for infants, it's fairly common to get good quality data even without anesthesia. And this is our study or article was about reviewing those, means to get good data. How are they reported? That's also important, because there was also one of the observations that we had in the article was that all of the details of the scans, the practical details, are not systematically reported. So we can guess that they might be operating similarly across studies, but if it's not written down, there's no way of confirming that. So yeah.
But then again, the research that you did, or the going through all the papers, you find certain patterns that were similar between most of the studies. And also that these measures can be implemented into the clinical to reduce anesthesia, right?
There were not that many studies that had actually kind of implemented the same, but that's the case. There were a few clinical studies, like among 86 studies that we actually ended up reviewing, was it 3 maybe? So like a minority of them will be, from clinical purposes, but they actually performed the scans with roughly the same procedures as for scientific purposes or research purposes only. So yeah, like the overall things or themes that we ended up reviewing and were roughly kind of repeating patterns on the studies were like timing of the visit, trying to match that to the daily rhythm of the families. And of course, that's actually easier for neonates or really young infants because they are sleeping so much. So it's kind of maybe the most typical like technique in the scans would be feed and swaddle. So kind of just having the family come in, feeding the infant, and then usually they fall asleep, usually. And if it's successful, then, starting the scan during natural sleep. And yeah, feeding before the scan was basically the most common preparation procedure for all of the scans. Then most of the time for young infants, the scans are performed during sleep. Of course, it's not, infant sleep can be quite restless. It's kind of sleep twitches, but if you are able to perform the scans in between like these little periods of motion, then the data quality is really, really good. And kind of this goes back into planning of the sequences. If they are sufficiently short in duration, that there's a really good chance that there will be a good quality data. Cool. And then for the scans, when the infants are actually placed onto the scanner bed, it was really common in studies to use some kind of soft immobilization, meaning there's this kind of vacuum mattress that you can use. It basically helps the infant to stay in a position roughly like this or whatever position their hands are in, so that they will not like laying recklessly on the bed. And kind of also like this throwing on a blanket, so kind of it also looks nice objectively. Then of course one of the key things that basically all studies must be somehow doing is hearing protection. And many of the studies use double protection, so kind of using some kind of blocks and then the standard or slightly modified scanner hearing protection devices. Yeah, for some of the studies, they included also kind of monitoring the infants. So that could be something like pulse or research staff in the room. For some studies, there's also kind of pediatrician or somebody who actually has clinical training to do something if something goes wrong. Yeah. These are some examples of the main themes that we ended up reviewing. And kind of typical preparation steps as well.
I read that some studies have used CDs. They gave the parents CDs to prepare the child for the noises. There weren't many of the studies that did that, but there's sort of giving them an opportunity to expose them to the environment and the sounds in the environment before going to the scan. Did you see any type of other measures that they could do at home before going to the scan?
Yeah, this is partly out of the review as well, because not many studies included like follow-ups from infancy to later ages as well. But I think it's could be kind of beneficial for the infants as well. Of course, it's the scanner noises are quite different from the everyday kind of audiovisual stimulus that you get or audio stimuli. But yeah, I think it's even more important for older age groups, especially for older children from age 4, for example, that are basically comprehending, and there's a lot of cognitive and emotional processing already that's related to the actual scanning events. And for the 5-year-old scans that we have done here, we basically used a home training protocol that included, introducing, here are the scanner noises, if you can listen to them, please, training to stay still, like calming down, delivering the hearing protection so they can get familiar with that. So kind of at-home preparation is even more crucial for older age groups, I'd say.
Yeah. And now that you started to do the study for like older up to 9 years old, is that something that you've increased in order to make them better prepared for a scan, or is it the similar?
Hard to say. We're just preparing, so we haven't done any pilots for 5-year-olds. But that's definitely kind of, we're looking into whether or not it's more fruitful to do that preparation at home, or should we kind of, for 9-year-olds, do everything at the scan site.
Yeah.
Probably that's going to be the elements that we're planning on introducing are most likely going to be the same. So the noises and, what the head coil. The head coil is probably the kind of trickiest part because it is quite close to the face.
Yeah.
So, the participants can try, it's going to be like this when you're in the scanner. So they know what they're, headed against.
Yeah. Yeah, and it's a good point where you say there about the head coil, because it's when we have a mock scanner at our office where we also have a head coil, and when we ask people to put on the head coil, they're more like, no, thank you, I'm fine. I don't want the head coil because it's intimidating in many ways.
Yeah, that's it. And then there's a lot of kind of inter-individual, or it's really personal how uncomfortable or comfortable people are with that. So kind of it's a good thing that you get to try how does it actually feel like. And of course, for I have to come back to infant scans. We did our infant scans with an adult coil, so there the coil is massive, it's big, and you have to position really really carefully, just not to be on a funny location in the field of view. And for the 5-year-olds, of course, it's almost the same as for adults, but still there's a lot of kind of like cushioning and things that you will have to pay attention to in order to make the laying in the scanner comfortable as possible.
Yeah. You talked about the feed and tuck. Was that
the feed and swaddle? That's one of the
swaddle. Yeah. That's very interesting, because in terms of if you look at the fear response, which is fight or flight, we call that fight or flight. But the opposite of fight or flight is rest and digest, which is really the same thing. So you're actually putting the children or the infants in a state where they get the food, they relax a lot. There's a lot of studies to show how food is a way of coping with stress. But the same thing also with tucking them into something that's worn and made for them heavy, that causes them to calm down. So is there many hospitals that use these strategies for infants? Are you aware of that?
No, that's the thing, and it was quite difficult to actually find out from the articles, because of course the scientific literature that we review is kind of mostly on research. So again, there were only a few studies that were basically reporting, successes in clinical scans. So I'm guessing there are many hospitals, but wasn't really easy to kind of scope how many of the hospitals might be opting out and when. Because of course there are also many situations where anesthesia is required and is beneficial for everyone for speeding up the diagnosis or that sort of thing. So maybe I hope that kind of these type of reviews and people that are reporting successful clinical scan will also kind of activate hospitals or radiology departments to map out, when and where we could be using or doing the scans without anesthesia in which sort of situations, because of course that will also have to be decided, based on the infrastructure and the personnel as well.
Yeah, because that was something you mentioned in the paper, that there is a lack of data for when to use these strategies. Am I correct? So it would be beneficial that those hospitals that actually use it, that they write down some of the criteria for when to use it and in which situation it's beneficial to use it, because that could reduce the use of anesthesia and could be replicated, correct?
Yeah, and then kind of, I suppose, kind of the ideal scenario would be that they would also describe the infrastructure, like personnel. Like we had radiographers that have worked this many years and this many years with infants, for example. So that will help kind of just getting a realistic picture on how, much expertise or training or, other type of, and this can all boil down to kind of hospital specific things like length of transport. If you have to be at a really like a remote location, and then there's going to be a long ride to the MRI, for example, as compared to riding an elevator downstairs. So all these can kind of have an influence on the final success rates. So yeah, kind of ideally, there could be some kind of, this is our infrastructure, this is how we do things, and this is our, team that takes care of this.
So the more detailed the whole picture is, like from a big point of view down to the nitty-gritty of what is happening inside the MR room, is important in order to get to find the factors that are contributing to a successful scan.
And of course, our review was able to map out this at the scanner or right before the scan events quite well. But of course, this kind of, especially for the clinical scan, it's the bigger picture has a kind of larger relevance than for this kind of voluntary participants coming in for scans type of scenarios.
Yeah, I think it was very interesting, the factor that you said with personnel, radiographers, and how much expertise they have, what experience they've had, how many years they've had, and so on. Because I think that's one of the things that I see and really emphasis is the competence of the radiographers or the MR tech is essential, and for them to really know how to deal with certain situations or different types of patients in order to calm them down is super important. But I'm not sure how it is in Finland, but in I know for sure in Norway and Denmark it's not a part of their training.
I don't think it is. And for our scans, for our infant scans, and for the 5-year-olds as well, we're really lucky to have one radiographer that had done one rather large, data collection for a study that studied preterm and term-born infants. So she already had a lot of expertise that she basically shared with us when we were collecting the data. So kind of having this one really skilled and experienced individual actually made our data collection a lot more easier. So even even one single person can make a huge difference in terms of this kind of accumulating or infant scan without anesthesia expertise on that.
What other types of measures did you find that were contributing to a successful scan for the infants?
One of the kind of, this might be counterintuitive even, is that, younger infants are usually easier to scan because they tend to sleep for longer periods of time and also sleep more reliably after feeding. So that's actually, and I kind of might not think it that way, that the youngest ones would be the trickiest, but in terms of this type of feed and swaddles, sleeping infant scans, that's actually kind of tends to be easier. We were unable to do any type of statistics on this because the reporting of things varies and everything. But kind of that was the impression, that the success rates are a little bit higher for younger infants, and this is but I think, the things that I just listed, kind of the themes that people have incorporated, all of these seem to be contributing to more successful scans. And of course, kind of comparing which of the measures are the most beneficial or everything, that's going to be tricky, and it wasn't possible for the reviewed studies because there's just so much differences in how things are reported, could be different countries. So kind of one should have one research center doing this, like systematically altering something in the protocol, or some kind of collaborative effort where different sites are experimenting how well they are able to do the scans.
Got it. But also in terms of one thing that I noted down from the study was scan duration was also something that was mentioned. What can a clinic do in terms of scan duration in order to increase the success rate?
Yeah, I suppose the main point is that the shorter you are able to image the stuff that you need, the better. So our own data collection, many of the data collections that it's not systematically reported. It's about 50% of the studies that report the total scanning duration, and this is of course also a little bit it's kind of hindering the comparisons, because you don't really know if that study did 1.5 hour data collection and we did 15. Our success rates would be, of course, that's intuitive that they would be better for the shorter data collection period. We were able to do, so our data collection took about 60 minutes and we were able to get relatively high success rates with that already. But ideally, I think, pushing them down, and then you could in principle do that with modern sequences, halving that, so 30 minutes or even 20 minutes would give a lot of data. And I'm not exactly familiar, of course, that depends also on the kind of clinical indication that the scans are ordered for, but that should be doable for the clinical scans as well, kind of just trying to optimize. And maybe some of the clinical scans don't have to be as accurate. Like I'm talking about the spatial resolution of the images. So if you're good enough with lower spatial resolution, that's one way of speeding up the data acquisition.
Yeah, and that's very individual based on case to case, and that's probably something that the dialogue between the radiographer and the radiologist has to be very clear on what does the radiologist need in order to create a diagnosis for the patient. And but if you were to take some of the principles or measures that you found while going through all these studies, and you were to go to a clinic that or a MR department that do clinical procedures, what would you give them of advice in order to improve the process so that they can see a reduction, that might see a reduction in use of anesthesia?
So probably my first message would be that, it's possible, and people have done this frequently in research purposes and, in some cases for clinical purposes as well. It should be worthwhile to try. Like I think there are good grounds in, trying to minimize the amount of anesthesia that is required for clinical scans as well. So kind of first message being that it's possible, maybe you could try it out as well. And then kind of if I were to engage in a conversation with a clinical team, I would also point out that it might be beneficial to kind of minimize the data acquisition time and schedule extra buffer time for the visit. So if things are not working, feeding the first time and then the infant doesn't fall asleep, so then they could have an additional scan or more time to try that again. Because I suppose that's of course for the anesthesia and sedation, it's easy because you can schedule that. And that's probably one of the kind of at the practical level things that might be kind of hindering the use of natural sleep scans. So kind of, I would encourage them to try. And I would be happy to, of course, share these procedures and how many studies have successfully done that. And maybe, one of the things we haven't discussed was that we also share some tips on how, when the infant is in the scanner, and if he or she wakes up, what we can do, just kind of tapping the pacifier or rubbing the baby. It's really what, parents might be doing at home as well to calm the baby down if they don't want to be pick the baby up. Really simple things, but you can do them whilst the baby is in the scanner as well.
So that might be like reaching someone being inside the scanner at the same time, scanning room, and then reaching in, like stroking them on their leg or something like that in order to
rubbing their tummy or tapping the pacifier, so that will activate their kind of the suckling response. Yeah, really simple things. But of course, as we stress in the article as well, it's you know, we usually left the scan on, so the kind of scanner sounds will be there, but we always read it, the scans, because there's a possibility that additional person in the scanner might affect the image quality as well. So yeah, but that's kind of if the infant is restless, not crying or woken up. These are simple tricks that can help this, help the team to continue with the scans.
Yeah, I really liked the advice that you gave was that it's actually possible, because I think there's so many out there who think that it's not, and that it's they're so used to using anesthesia as the go-to method, but haven't actually looked into alternative measures that could give the same result and maybe even faster and more cost efficient.
That's the thing, the cost effectiveness, because if you are including anesthesia, that also includes enrolling additional clinical staff. So, I suppose it boils down to whether or not it's, if you just think about money, it's more cost effective to book the scanner for a longer time, or the whole team for 15 minutes, for example.
Yeah, and I also spoke with someone from Denmark, Melanie Guns. She done similar, but for older children specifically. They've done a lot of measures. They even built a mock scanner, which I think is really cool to sort of increase the preparation. And she said that if you have a patient that needs anesthesia, they have to block 2 or 3 times, 2 or 3 scanning slots to just prepare the patient for anesthesia. You also have to bring in the staff, at least 2 or 3 people. There's a higher risk, there's a higher cost. But I also think one of the reasons why people always go to anesthesia is because, one, it works, and it's probably one of the only measures they know about. So that's why I really like the advice that it is possible. There are alternatives that you could try. So that's really nice. What other tips and tricks did you learn that a clinic could easily implement to get higher success rate?
Yeah, I don't know if I mentioned also kind of reducing maybe this sequence length. That's one. Then taking care of this. I suppose this all boils down to having a good preparation. So taking the family, feed and swaddle. There's a lot of time. Everybody's calm. I think that's I attended a few infant scans myself, or was involved in the data collection. It's really important to take the family somehow. Take them, have them involved. Be nice, calm, assuring. So there's a lot of this kind of soft things that the staff can take. And I suppose that's actually one of the key elements or keys to success, if you come to think of that. Yeah, and then if the baby is restless, not panicking, just trying to calm the baby down. If it doesn't work, then, feed and swaddle again and try. So kind of maybe just take it nice and easy, because it's highly possible that you will get the scans in the end of the day.
Yeah, and I think that's maybe where people will start to get stressed, because they have this time slot, they have this clock that's ticking, and they want to be efficient, but then they might push it too far and they become ineffective. So I also agree in terms of calming down. and you see that same with older patients, young children, grown-ups. If you create a stressful environment, then you add stress to the whole experience. But if the radiographer is calm and is at ease, then you're at ease. I sometimes when I do talks about this, I ask people to imagine that they're skydiving for the first time, and your instructor, he's stressed. How would you feel?
Yeah, that's a good metaphor for the, and of course it varies in every age group. And of course for the infant, it's the most important thing is to, somehow discuss with them that can comprehend, meaning the parents or adults in the room. But yeah, for older children, that's equally important to engage with the child.
It is. So tell me a bit more about if you can and if you will, about the next study that you're doing. How will that be different from the study that you've done in the past?
There are many. Well, it's in planning, so I can't really describe anything tangible at this point. But maybe I can discuss for the 5-year-old. That we collected. So, of course, building on longitudinal data on neurocognitive development. So probably the main theme for that data set is, of course, the FinBrain main theme, meaning the early life exposures and especially maternal health during pregnancy and how that might affect child behavior. But there's this really strong emphasis on neurocognition and socio-emotional development and their neural correlates on, how the brain features might explain those type of skills in the children. So that's one of the main research questions. And for those data collection, we use roughly the same 1-hour MRI protocol, but of course now the children are awake. Again, we had home preparations, and then about 1.5 hour, 2-hour preparation at the scan site. That's, we're preparing that the children are not hungry or they don't have to go to the toilet. Going through instructions how they can pause the scan. So we use this kind of messaging ball that they can throw the ball if they want out. So they don't have to sleep or no, not sleep. They don't have to move or do anything kind of that could possibly ruin the scan. It's enough that they drop the ball, so we know that at the end of the sequence, there's going to be a need for a break for the child. So kind of this really kind of a lot emphasis on the preparation, communication, and safety, and one of our research nurses, as we call them, maybe you could call that child life specialist. That's usually what kind of a term that is frequently used for these people that are taking care of the scan preparations. And she was wonderful in kind of providing the preparations and also everything at the scanner, so kind of supervising the whole scanning visit. And the feedback from our visits was really excellent, like 4.9 out of 5. So we're really happy in kind of, we were able to get good quality data, but we were also the most important goal of, keeping our participants happy, and we're successful in the, let's say, psychological safety. That's probably one of the keywords for, otherwise successful scan visits.
Because there are two parties here. There are you who need the data, and then there are the participants or patients that are actually providing you the data. And by doing good preparation, you're actually managing to make everyone happy. So it's a win-win situation. That's really
and of course, I have to say that of course, it's important for the families to, be successful or succeed in taking the MRI. And sometimes for the children as well, they might be disappointed if something doesn't work out. It's human to want to be kind of, successful in whatever they're trying to do. So kind of it's really important to try to be as prepared as possible.
In terms of the home preparation for the 5-year-old, what type of home preparation, what tasks do you give them to
So
prepare
yeah,
for this?
kind of course, there was information. So this is
Mhm.
actually the information comes first. So basically, it's adult consent. So the adults are allowing the studies, and child assent, so that the child is willing to come.
Yeah.
And that is based on basically a leaflet or this kind of information material that's written basically partly for the adults and partly for the children. So the adults read the text for the children beforehand. And then the actual kind of, this is the start, and the preparations were scanner sounds, and then it's kind of, it's a play where they have to kind of a statue play, maybe
Yeah,
statue
statue play.
game,
Yeah.
statue
Yeah.
game. Or then, and they think they kind of have an idea if they want to come to space rocket journey or submarine journey, something that is kind of exotic and requires you to stay still. So
Yeah.
kind of having their own freedom in, basically planning what's the backdrop for their event or scan.
Yeah. Cool. I like that. That's really cool, because what you're actually doing that, you're reframing the experience. Yeah. And you get them to choose what adventure they're going on. That's really nice. And the nurse that works, you call it scientific nurse? Yeah.
Or research nurse. That
Research
it's
nurse.
basically translation from Finnish. I don't know if that's
Yeah.
an international term, but basically kind of expert research staff. Yeah.
And what does he or she do? You said 2 hours before the scan, the family meets up in preparation. And what are the common things that you do? You mentioned about um, not being hungry, not needing to go to the bathroom. What else do they do during those 2 hours?
So I suppose, one of the main things is that, so the visits were run by our research nurse and our PhD students. So there would be one student, PhD student, and the research nurse for each and every visit. And probably and in the beginning, the most important thing is to get to know the child and the family. So it's a lot about just waiting when the child is open up to do any activities at all, or be playful. So there might be, for some children that happens right away, and for some children they will have to wait for, let's say, 20 minutes or 30 minutes before the child warms up. And once that's happened, so usually they started with light snack. So that's the assuring they're not hungry. And that's also a really nice way of kind of, getting to know each other and just, somehow grasping the emotional atmosphere and trying to make that as positive as possible. And then they again played this statue game with basically had a tent, the small child tent that they kind of just laying down there. And then we had because we were not able to get a mock scanner, the total scanner, we made a wooden head coil replica of our scanner. And then they tried that. So kind of basically just going into the tent. So it's going to be kind of confined, but not claustrophobic. So it's still a relatively large space. And then including the head coil also. So kind of going in and trying the head coil and how close that's going to be. So yeah, that type of preparation events.
So really exposing the patient or the participant for what's about to happen gradually in a safe environment where you have plenty of time.
Yes, so that's the idea. So maybe kind of the backdrop on this on our end, that we did the scans mostly on weekends when the scanning facilities are basically used by no one else. So we had the whole facility, a lot of space, and no pressure at all to start the scans, or more importantly, even to finish the scans on time. So yeah. But we of course tried to, there's kind of having many families come in the same day. So of course we also had our limits, but they were not tight at all. So kind of the idea was to do one scan, there's going to be a break for the staff, the personnel, and then another one.
And when you use these procedures, how well did you manage to stick on the time schedule that you have? Were you much off, or were you almost on?
So yeah, I think it took, our data collection was about a little bit shy of 3 years in duration.
Yeah.
And there were ups and downs. There was this COVID pandemic that stopped
Yeah.
our scanning, and we had to, restart that. So in the beginning, it tended to take longer, and that, about maybe 2.5 hours on average. And as the data collection proceeded, that came down to a little bit less than 2 hours even. So
Yeah.
it kind of, but that's not every time. So you couldn't kind of schedule 2 hours. It's highly dependent on the child and the family how that goes.
Yeah, and that included in those 2 hours, how much of the time was inside the scanner room?
So yeah, around 60 minutes, but that also depended. So kind of in our protocol, we always wanted to have the structural scans because those are the basic scans, T1 weighted scans that we need for structural MRI analysis. So kind of the scan type that you would need most often, and often for analyzing or pre-processing the other modalities as well. So it's like structural MRI, then diffusion MRI, and then resting state, or actually it was naturalistic fMRI where they were watching a video recording during the data acquisition. So kind of now if the children were, somehow uncomfortable or wanted to stop, we stopped. So a maximum of 60 minutes in the scanner. Sometimes that's a lot less. Could be something like 15 minutes, and we still have some data from that participant.
Yeah, but even though, like, I think for many radiographers, hearing that a 5-year-old child is 60 minutes in the scanner is awake might sound like more like a miracle than a possibility. But so based on their experience, but it's very interesting to see, since when you when you start an MRI machine, the clock and the money starts ticking, and that's where a lot of the pressure comes, I think. But by doing good preparation before the scanner, then you're actually able to have a more like streamlined sequences and a streamlined scan during that scan room. Am I correct there? Was that your experience?
So, if we had unlimited resources, I would have probably doubled our staff and have 2 different preparation rooms so we could scan all the time. So this is in principle, would be possible to make it, as almost as in normal MRI, where the patient is received and prepared briefly in that scenario, of course, and then scanned, and then there's this kind of, walking out, of course. So we always need these preparation phases, and they always take place outside of the, the scanning room. So
yeah, and I think that could be probably one of the hardest thing to do clinically. But I also think that it's a challenge that you should that should be looked at, because if you do well preparation of the patient at home and at the hospital, you might save yourself for a lot of frustration, a lot of time, and also use of anesthesia.
Yeah, I forgot to mention that I think this is important, that we allowed the children to look videos whilst they were recording the structural MRI, and then we had kind of research video for the functional MRI. So that they weren't able to decide that. We decided that for them, but everything else they could choose. And we took kind of negotiated with the parents as well. So kind of we didn't want anything that's too emotional or that something that the child doesn't know about, because it can happen that it's it's scary or even funny, because that will also ruin the scans if the child is laughing real hard. There's going to be emotion. So it's kind of really careful selection of the videos that they were watching as well.
And how was your experience with using video entertainment for those children? What was the effect?
So for most participants, I think that's really one of the key components of making a successful scan, at least initially, because that's tend to they were watching that through a mirror from the head coil on top of the head coil. So and they were also able to see their parents that were allowed into the room. Yeah. So that created a lot of safety, that view, and then that there's something that they can pay attention to, or something else that they can focus on apart from being in the MRI machine. But yeah, of course, there's pros and cons. If it's too funny or emotional or whatever, it can also lower the success rates.
Yeah, you don't show a picture of a snake.
Yeah, no, not really.
No.
That's probably not a good idea. Like all of a sudden. Surprise.
Surprise.
Yeah.
Yeah, or like a scary movie of MRI scan.
Yeah, that would never work.
Never work. But it's so interesting because when it comes to both anxiety and movement, if you try to I always give this as an exercise. Take a chair, put it next to a white wall, close to a white wall, sit and look at the white wall and try not to move. Best of luck. It's not easy because you're boring. But if you put them in front if you put yourself then in front of a television and try not to move, then it's much easier because you actually have something to draw your attention to.
Yeah, exactly. And I'm thinking at least the beginning of the scan, which tends to be the where the excitement is at the highest peak. So that it really helps if there's something where you can pay your attention. Refocus from the exotic thing that's going on around you.
Yeah, and that's also the thing with fear. It peaks and then it goes down. It becomes calm. That's once you've been exposed to the environment long enough, it goes down.
Yeah, exactly.
Cool. Well, is there anything we need to wrap up now? But is there anything more that you would like to mention, or like the last advice that clinicians can take from the way you do it in research? What would that be?
So I think of course, our review article is quite recent, but I think it's already almost outdated because there are many groups that are doing fetal scanning, infant and neonatal scanning, and more groups like open access data sets that are performing research scans for 0 to 5-year-olds or 5 to 21-year-olds, for example. So I think overall there's going to be a lot more child and infant and developmental brain studies worldwide. And maybe I should mention that there's one society that's particularly interesting. It's called Fetal, Infant, and Toddler Neuroimaging Group, so FITING as they call it. So basically societies like these actually have individuals and experienced investigators that have been doing this type of work for long periods of time. So would be wonderful if clinicians started somehow grasping and getting that information that's already embedded in this research realm of things. That would be a wonderful start. And I think there are many possibilities, more than a few years back.
Really cool.
Yeah.
Thank you so much for the interview, Jetro. This has been a pleasure. And I really hope that people take some of your advice and most of all believe that it's actually possible to make some improvements by making small adjustments. So thank you.
Thank you. Thank you so much.
Good. That was really good. Well done.
Yeah, thank you. Wonderful.